Dr. Melmed is the director of the Clinical Research Inflammatory Bowel and Immunobiology Research Institute at Cedars-Sinai. He's also the associate director of the Karsh Division of Gastroenterology and Hepatology at the Department of Medicine. He's a professor of medicine at Cedars-Sinai and the David Geffen School of Medicine at UCLA. He earned his medical degree from the Albert Einstein College of Medicine and a Master of Science in Clinical Research from UCLA. He completed his gastroenterology fellowship at the University of California, LA. He has very many clinical research interests in inflammatory bowel disease. He is very involved in clinical trials, health services research, preventative care, quality improvement, translation, genotype, phenotype studies, and surgical outcomes. He has authored or co-authored more than 250 articles in peer-reviewed journals and several book chapters. There's more information about Dr. Melmed also in our materials that we sent about this talk, and you can find more about him at Cedars-Sinai. And I'm going to hand it over to you right now to get started. And again, like if you have questions, you can put them in the chat, or you can wait until he's done with his talk and just ask them. So, and thank you everybody for being here.
Thank you, Stacy, and thank you also to Betty for organizing tonight. It's really a pleasure and a privilege to be here speaking to you. And I just want to congratulate you on a tremendous year that you guys have had and the incredible work that you do as an advocacy organization for patients and the support that you give to us at Cedars-Sinai as well as other research centers around the country. It really is a phenomenal effort that you have put together, and it's a privilege to be speaking with you tonight as part of this program. What I've put together is some slides on my opinion of where things are at with respect to translating research and how we bring research findings into the clinic, how we bring it into patient care on our day-to-day basis as physicians, and then also to give a glimpse of what I think. Again, this is all my opinion. Where things might be headed. So, just bear with me as I pull up some slides here.
Of course.
Okay. Are you seeing my slides in presentation mode?
Yeah, looks great.
Okay. All right. So thank you, Betty, for helping me refine the title, Translating the Latest IBD Research into Clinical Practice. And what I want to do over the next 35 minutes or so is to talk to you about concepts of research and again, how we bring them practically into the clinic. And I want to preface this by using the term translational research. There's a lot of different kinds of research, and tonight I'm going to touch on translational research, clinical research, quality improvement research. But it's different, I think, than when most people think about research. They think about like a scientist in a lab developing the next drug that's going to cure cancer, or cure, in this case, IBD, Crohn's disease, ulcerative colitis. And what I do is in my research areas is taking those discoveries that the scientists are making in the lab to the next level. And so actually the NIH has defined translational research into different categories. We have lab discoveries that are then taken into human trials, and we do some clinical trials that are then moved into clinical guidelines. And there's a whole series of research that needs to take what do we learn in a clinical trial and say, well, how is this relevant in the real world to bring it into a clinical guideline to teach all doctors how to practice. And then we have guidelines that get translated into routine practice and population health. And I'm going to touch a little bit about some population health studies and research in population health where we can actually demonstrate that it's not just helping the patient in front of us, but helping a population of patients where we can potentially have a really big impact on a lot of people at once with research that we do. I want to structure my remarks in terms of this outline here. Where are we at? I want to talk about some new drugs, which I think are very exciting and only recently been into the clinical practice arena. But I also want to talk about where we're at with research on reconfiguration of old drugs. We've got some really fantastic medications that have been around for a very long time that we're learning now how to use better. And those are achieving better outcomes than we've ever achieved with these older drugs. We have better ways to use old drugs, And we are also learning that we probably have better ways to use all the drugs that we use in IBD. And the research that is coming out of a trial that teaches us how to use a new drug, how to use an old drug better might actually be more impactful than the development of a new drug, because we may be able to achieve better outcomes for a larger group of people. I want to talk a little bit about the role of surgery. I think there's been an evolution in the research about how we think about surgery for inflammatory bowel disease, both for Crohn's disease and for ulcerative colitis, but in particular for Crohn's disease. And then some research I'll share with you that we're doing at Cedars-Sinai about preparation for surgery and how we can achieve better outcomes that way when people do end up with surgery. And then finally, to touch on some quality of care research about impacting large populations. That's where we're at. But what about where we're going? I want to also share with you some thoughts that I have about what might be the next new drug or drugs, predictive biomarkers, what is the next paradigm shift in how we use our drugs and how we think about surgery, what is the role as we think about the future of virtual reality and artificial intelligence, and how is that relevant to IBD? And I'm just going to give you a little glimpse of some of the projects that we're involved with, but there's a whole explosion of research in this field as well, which merits its own separate talk. And then, and as well as remote monitoring, I think we're moving a lot of, we could imagine moving a lot of the things that we do in the clinic, in the hospital, in the procedure room, to the home, where we can have a much more convenient way of monitoring inflammatory bowel disease. And so I've broken it up as sort of individual level research and population-based research, but a lot of the things that we talk about can be relevant to individuals or they can be relevant to populations. I think to me, one of the most exciting things in the research arena, as we think about translational research, is bringing those new drug discoveries to the clinic. Just to give you a quick timeline, and I've put here on the right side of the screen an exponential curve, because that's what it feels like in our field with the evolution of availability of what we call advanced therapies. We used to call it, by the way, biologic therapies, but now we are also have the added small molecules. I'll talk about JAK inhibitors in a little bit, but so the combination of biologics and small molecule therapies would be a sort of an umbrella term of what we call advanced therapies, and the first of which was infliximab or Remicade, which was introduced in 1998. And this was the first drug, by the way, this was the first drug approved by the FDA for Crohn's disease, just a little known trivia fact. The first drug approved for Crohn's disease wasn't until 1998. And then this was the first drug, and this is what we call ushering the era of biologic therapy, where we can actually achieve steroid-free remission with healing of the colon. Healing of the colon in about 20 to 30% of people that took this drug, which was a remarkable achievement. Up until then, we had not had or not seen true healing of the colon, healing of the bowel with any medications. And then we had about 16 years before the next drug class was developed, and that was the introduction of vedolizumab or Entyvio. And then a couple years later, we had Stelara, ustekinumab, and then a couple years later, our first JAK inhibitor, which was Xeljanz. And then since 2022, we've had 6 drugs approved, and so it just feels like we have acceleration of the availability and development of drugs. We have 3 IL-23s. You may have heard of Skyrizi, Tremfya, Omvo. We have 2 JAK inhibitors, Xeljanz and Rinvoq. We have S1P receptor antagonists, Velsipity. And so the availability of these new drugs has really, in my opinion, been one of the major game changes in our field, and probably in almost any field in medicine that has truly been accelerated in the last few years. And these newer, later drugs are overall, we see with very favorable safety profiles, greater likelihood of efficacy, and greater convenience for people. We're not talking about necessarily infusions anymore. We're talking about injections. We're not talking about injections every 2 weeks. We're talking about injections every 4 weeks or every 8 weeks. And so really to make things more accessible and more convenient for patients. I just wanted to highlight here, these are the drug classes. We have 5 different drug classes in IBD as currently available options, and I'm not going to go through all of these details, but we have, we have now a number of families to choose from, and for a long time, really until 2016, we only had that one family, that anti-TNF class, which included Remicade and Humira and Cimzia. and Symphony, but really we were limited to that one green drug class all the way on the left, and only since 2016 we've had this explosion of additional therapies that are now available, which gives us a lot more options to choose from for different kinds of clinical scenarios. But in addition to those fantastic new drugs, and by the way, it takes probably close to 10 to 12 years for a drug to be identified as a drug target and moving through the whole clinical trial process. And it takes a number of years before that, before it even makes it into clinical trials. So even though we're seeing this explosion of drugs today in the last 2 or 3 years, those drugs, Skyrizi, Tremfya, those have been in development for well over a decade, and it really behooves us to recognize that most drugs that start that process do not end up seeing the light of day. And so we're very fortunate in our field to have so many of these new drugs available in the very recent past. But we've also got reconfiguration of old drugs. As I mentioned, Remicade was introduced in 1998. That's been around the longest. And we now have, in 2024, the introduction of infliximab injection. So Remicade, as infliximab drug, is an IV drug. Takes 2 hours for a typical infusion, and it's administered every 8 weeks. But oftentimes we administer it more frequently. So, in addition to the older drugs that now are reformulated, we also have learned that there's better ways to use old drugs. When Remicade first came out, again, I'm picking on Remicade because it's our oldest friend, if you will. It came out in 1998. But we learned that when it first came out, we were using it wrong. Initially, it was only episodic, which means that we used it in episodes. So if you had a flare, you took a dose of Remicade, and then you were done until your next flare, which might not be for 6 months. And then you had a flare up again, you took a dose of Remicade. And what happened was that it stopped working. Those of you that are on Remicade or have been on Remicade know that you have to continue to use it in a maintenance form because otherwise you develop antibodies to the drug, and those antibodies render the drug less effective over time or increase risks of reactions. And so we didn't know that at first, but we learned that. So initially we used it only episodic, then we started using it for maintenance therapy. So we learned that you have to give a dose every 8 weeks to maintain that effect of the drug. Then we realized that Remicade worked much better when we combined it with another drug like azathioprine or 6-mercaptopurine or methotrexate. And so then we started using what's called combination therapy when it came to Remicade specifically. Then we learned that, well, we can actually measure drug levels, and we need a minimum amount of drug in the system in order to determine that the drug is effective. And so we started measuring drug levels. And then by measuring drug levels, we were able to learn how to properly tailor the dose. Some of you may be familiar with other drugs in medicine where we tailor the dose to the measurement of the drug. And so this was a way that where we learned how to use an old drug much better. And so those initial 20 to 30% response rates that we saw with Remicade were now shifted up to 40, 50% because of our better ways of using that drug. Next slide. This is we call a conceptual framework for, on the left side, how we have historically thought about treatment for IBD, and then on the right side, sort of a future model of that. And I just want to walk you through this because this is a really important concept of why the framework of treatment is shifting to be earlier and earlier in the disease course. In the blue line that you see kind of looking like an EKG, yeah, thank you. That is intended to represent disease activity. So when it's up, that's like a disease flare, you have symptoms, and when it's down, you don't have symptoms. You don't appreciate that the disease is active. However, that yellow line that's going on in the background, that yellow line is cumulative bowel damage. That's that, you see that on the y-axis, bowel damage that accumulates over time. So even though you have intermittent flare-ups, there is cumulative bowel damage that occurs each time there is inflammation. And eventually, those will develop into complications, particularly in Crohn's disease. They can develop into strictures, which is narrowing of the bowel, or fistula, which is a tunnel of a deep ulcer, a cratered ulcer that penetrates right through the wall of the bowel. And oftentimes, those are complications that need surgery. And we know that undertreated Crohn's disease or untreated Crohn's disease will lead to a complication about 80% of the time. 80% of people before the era of biologics needed surgery to fix one of these complications. And so, this concept of a window of opportunity, that's that early pink shaded area, is an opportunity where we think before bowel damage sets in, because bowel damage, by the way, then it's too late for medications to work. We think about it like a forest fire. If the fire is burning, we can put out the fire. But if the fire is already burnt through and moved on to the next piece of the forest, the part that it leaves behind, it's not responsive anymore to putting out that fire because the damage is already there. That scar tissue has set in and it's already there and it's not reversible. And so the goal then, if we shift now to the right side of the screen, the goal is to treat early and minimize those flares and therefore minimize the accumulation of irreversible bowel damage, ideally limiting or reducing or preventing those complications from forming and preventing the need for surgery ever. And so that's sort of the goal of early treatment and why we think early treatment is important. Let's go to the next slide. Um, and so the probably, in my opinion, the most important study that's been published in our field in the last few years is this study here. This is a study where they did what's called a um, top-down versus step-up treatment. This was a large study. It was done in Europe, multi-center, multinational, um, randomized controlled trial of 386 newly diagnosed patients with Crohn's disease. So these are people who were taken into this trial immediately after diagnosis. There was an average of 15 days from their diagnosis where they were enrolled into this trial, and then they were randomized to receive infliximab or Remicade plus azathioprine. That was the top-down arm versus step up. They were treated with steroids and azathioprine, and then they only started Remicade later on if they needed it. Um, and the outcomes from the study that they looked at within 12 months were to see did a patient require surgery, and how were they doing clinically? And so if you go to the next slide, you can see here the difference between the top-down and the step-up group. 79% of the top-down group achieved this endpoint of steroid-free remission and surgery-free remission. So at the end of a year. So these are remarkable numbers. We've never seen numbers like this. 80% essentially of patients responded to this approach of treatment. Remember, I told you earlier when Remicade was first approved, it had a 20 to 30% response rate for clinical remission. And here we're seeing steroid-free clinical remission with avoidance of surgery of 80% at 1 year. And it's the same drug. It's the same drug. This is still with Remicade. This is with infliximab combined with azathioprine. Compared to the step-up group, which were the patients that were not treated with Remicade up front, they had to earn it. They had to earn it by flaring up again after their initial course of steroids. And so I think, I'm calling this the most important trial because I hope that this trial really helps push our field to offering and recognizing the benefits of advanced therapy early in the disease as a way to truly modify the disease course rather than wait for patients to earn it, so to speak, because they've already got a complication, and that's when the decision is made to put them on an advanced therapy. That's probably already too late. In many cases, it's in the progress of developing those complications, but by treating early, and here again, within literally 2 weeks of diagnosis, we see these remarkable numbers.
And this study was from 2024, it says, right? So that's
Yes,
pretty recent.
yes, this is a recent study. Yeah,
Mhm.
this is a recent study.
And
I
I
mean,
guess this will help insurance hopefully too, to, see the value.
right.
Yeah.
Insurance companies often require, or historically have required, people to have failed, other therapies, more conventional therapies, before they will approve an advanced therapy. And so, I agree, Stacy. This is building the evidence that we need to present to insurance companies, and we're doing that.
Yeah.
Uh, so, exactly. But this concept of treating early is, I think, one that is It's met often with resistance when I give this talk to even physicians that have been practicing for years. Oh no, my patient doesn't need, advanced therapy until they declare themselves as needing it. But that's again, that's already too late. And also, I think many people, many patients are hesitant to start advanced therapies because of perceived risks. And I think that we as a medical community have to do a better job of learning how to communicate effectively around risks and benefits when it comes to decisions of treatment. It's hard to, um, recommend a treatment with potential risk to somebody when they feel well, even though we can potentially predict and foresee complications that arise in the future. The analogy that I give my patients when I talk about early therapy is blood pressure. I think we've done a nice job in the medical community of putting out there in public service messages that you have to control your blood pressure, even if you feel well, because we know that in the future that's going to lead to bad outcomes like heart attacks and strokes. And we don't wait for somebody to have a heart attack before we start them on blood pressure controlling medication, or hopefully not in most cases. Let's go to the next slide. Okay, so I've touched on surgery a little bit, and I want to kind of pivot now from talking about medications to talking about some research in surgery. And this is research that we have been doing at Cedars-Sinai with respect to helping patients go through surgery and preparing them optimally for surgery. Surgery's been compared to running a marathon. There's a lot of scientific articles saying what your body goes through when you run a marathon, the huge physiologic impact and changes that occur are similar to what a body goes through when you go through surgery, this enormous sort of metabolic hit that you take. And of course, those of those in the audience that have run marathons or have trained for major events like that know that you have to prepare. You have to prepare physically, mentally, nutritionally. And so the concept of prehabilitation, of getting ready before your surgery, has entered into medicine over the last couple of decades. But really, there's been very little in the IBD space about the potential benefits and even what prehabilitation before surgery could look like. Next slide. So we developed a program with funding from the Helmsley Charitable Trust to prepare patients for surgery beginning 4 weeks prior to surgery, and it lasts for 10 weeks. They have 7 visits with 4 providers. They see a dietitian, a physical therapist, a nurse practitioner, and a social worker. And they're addressing, you can go to the next slide. They're addressing physical health. Patients are provided an activity tracker. We have very specific exercises to strengthen those core muscles, which you need for abdominal surgery. We teach patients how to get out of bed the day after surgery, but we're doing this before surgery. There are now products available to help boost nutrition, help boost protein, just like you load up with carbohydrates before a big race with a big bowl of pasta the night before a marathon. We also carb load patients before surgery now, and actually carb loading before surgery has shown to significantly improve outcomes, and also focus on mental health, make sure patients have what they need from a support standpoint to get through surgery and anticipate what it's going to be like afterwards. Next slide. And these are our outcomes. We've shown that patients who go through a prehabilitation of up to 4 weeks prior to surgery have a much greater likelihood of no complications after surgery. And you can see here in the blue are patients who, we had about 100 patients who went through this prehabilitation program compared to in the orange, about 100 patients that did not. And these are patients at Cedars-Sinai over the last 3 years. And you can see that for those grade 0, which is essentially no complications, our prehab patients did much better. And then for each of those different grades of complications that could occur after surgery, which could require repeat surgery or ICU, everything was lower in patients who had prepared before surgery. It's a very simple concept, but addressing nutrition, diet, mental health, and physical conditioning and sleep, it turns out, it ends up being very important. Next slide. And we've also shown that you recover faster, lower rates of readmission, lower rates of reoperation with this prehabilitation. Next slide. Here's just a snapshot from people who were activity trackers during this preparation prehabilitation program, that those that slept better, this is sleep data. It's not so simple to track, but sleep efficiency is the idea of how much sleep, how much time spent in bed is actually spent sleeping and not being awake, tossing and turning. And so that's this concept called sleep efficiency. And those with greater sleep efficiency, the better night's sleep you got, meaning you go to bed, you go to sleep effectively, did actually better when it came to different surgical outcomes, including, by the way, length of stay. They ended up having shorter hospitalizations when they were better prepared prior to surgery. And you can skip ahead 2 slides. There we go. Yeah. I want to now pivot to talk about some population-based research, and this is through IBD Chorus. This is a nationwide quality improvement program where there are about 70 centers now, 70 IBD centers around the country, where we all get together and talk about how can we improve the quality of care for our patients as healthcare practices, and what changes can we learn from each other about ways that we can address needs for patients that can actually show improvement in outcomes. And next slide. And through an effort of working together, we've shown in thousands of patient visits, this is data from 20,000 patient visits over 15 months, that we can significantly improve various outcomes, including going to the emergency room, being hospitalized, needing steroids, needing opioids, and needing urgent care. Next slide. And we do this through some very simple, low-cost interventions that we call our urgent care toolkit. And we've now made this publicly available to all GI practices in the country. But basically, teaching healthcare providers how to prioritize the patients who are at higher risk, how to offer urgent care appointments. You call a doctor's office and you can't get in for 4 months, or if you need to get in, it's a strain to the system. How can we think about being able to manage our chronic care population in a way that facilitates the fact that we know people with IBD will have urgent issues and they will need to come in and they will need to be seen. Otherwise, they're going to end up in the emergency room. And many times we can potentially prevent that by offering some simple solutions to practices. And so that's this concept of quality improvement. And on the next slide, I can share with you some of the data that we've collected over the last, this is data over 7 years. Each one of those dots represents proportion of patients who have been in, reporting having been in the emergency room in the last 3 months. And if you follow the green line, which is the average of patients who have been in the emergency room, you can see that it's dropped from about 15% down to 10%. And then that green line over the last 4 years has been at 7.5%. That means that we've cut the proportion of patients who've been in the ER for their IBD in half through participation in this quality improvement initiative. And this is now, that's 60,000 patients have contributed to this data, and this is data that's being pooled from all of these practices around the country. Next slide. This is similar data, but this is looking at steroid use. And I'm sure I don't need to convince this audience that we want to try to minimize steroids. And we've shown through these quality improvement efforts that we can actually achieve lower rates of steroids through a quality improvement program. Next slide. Just to share with you what we're working on currently in this program, and I'm actually headed to Las Vegas tomorrow to the Crohn's and Colitis Congress for a meeting on this specific topic. And this doesn't sound like rocket science research. It's certainly not high technology, but we're tackling a very important question, because you can have the best drug in the world, but if you can't get the drug, it doesn't help you. And we, as a healthcare provider community, recognize that in IBD, when we prescribe a drug, it can be a long time before our patients actually get the drug. And we did a survey among these sites that are participating in our QI program. How long does it actually take from the moment you write the prescription until the patient actually gets the drug in their body? And you can see here we had over 500 patients data. And this is the proportion of patients receiving their first dose of drug: 26% within 2 weeks, 58% within 4 weeks. It took about 12 weeks before almost everybody got their first dose of drug. And like, how is this like, we're in 2025 in the United States, the best healthcare in the world. It takes 3 months essentially to get our patients, when we write a prescription, onto effective therapy. And we don't accept this for other conditions. And somebody walks into our office with pneumonia and we prescribe an antibiotic, they get an antibiotic that day. but we can see and we've learned from our IBD experience that in many cases it takes a long time. So this is now turned into a research question and a research project. I see Kathleen asks in the chat, why the delay? We have about 20 different reasons for the delay, and we've mapped out the process for what it actually takes from the moment for prescription to get drug into the body. And we're tackling that process. And this is going to be an enormous research effort and a research initiative for us in this program over the next couple of years. Next slide. So that's a bit of a snapshot about where we're at now. And I want to share with you some thoughts. And again, this is my opinion. So don't go buying stock in any company based on what I say. But where are we headed next? So if we go back to drugs, I think, of course, we always want new drugs. And I think, in my opinion, we probably have 30 new drugs in the pipeline in stage 2 or 3 FDA clinical trials. Stage 3 is the stage right before approval, and you need a couple of phase 3 trials to be positive in order to get approval. But what's exciting is this new drug class called the TL1A or anti-TL1A monoclonal antibodies. This drug was actually developed at Cedars in Steph Targan's lab. Some of you may know him or have heard of him. And so one of the first TL1A drug, TL1A is a master regulator of the immune system. And it's new. It's a new class, so it'll be different from any other drug that came out there. And now there are 4 different TL1A drugs in clinical trials with 4 different companies, and every one of them is trying to kind of race to the finish to get their drug really approved, but really to show that it works. And this is being looked at in both Crohn's disease and in ulcerative colitis. Now, what's exciting about this drug? Well, what's exciting, if you look on the right side of the screen, is that they have developed this drug with a concept of a biomarker. Some of you may be familiar with cancer. Like in cancer, now we have biomarkers that tell us what kind of drug should we treat this cancer with. If somebody has HER2 new positive breast cancer, we know that they will be a good candidate for a drug called Herceptin. Somebody has a biomarker negative breast cancer, we know that we need to treat with a different kind of drug. So that's really, I think, where we're headed in IBD is having biomarkers tell us what's the likelihood of a patient's response to a drug. And you can see based on the publication in the New England Journal of Medicine. Now, it's not black and white. It's not like only people with the biomarker respond, or if you don't have the biomarker, you don't respond. But when you looked at all comers, you had 55% versus 32% achieving clinical response. But if you're those that were biomarker positive, you had a much greater separation of a higher likelihood of response if you had the marker and a lower likelihood of response if you didn't have the marker. And so that was a phase 2 trial. Now we're waiting to see whether the phase 3 trial bears this out and whether this is true among the various different anti-TL1As under development. So stay tuned, but I think this could be that would be a real game changer in our field because right now we have a lot of options, but we don't know which one to use, and we don't necessarily have great guidance from at least biology to tell us that an individual might be more or less likely to respond to a given drug. Another thing that's exciting about this drug that hasn't yet been shown in human trials, but in animal studies, anti-TL1A seems to actually reverse fibrosis. And this would be a total game changer in IBD because we know that that scar tissue, that fibrosis that sets in, that's the bowel damage that occurs over long periods of inflammation, is irreversible right now. We cannot reverse it with therapy. That's when patients end up with surgery. But this has the potential, at least in animal studies right now that we've seen, to be an anti-fibrotic medication. And that again would be a real game changer, having an opportunity to use medicine where right now we only have an opportunity to use surgery. Next slide. Some other things that I think are exciting about the future. AI, virtual reality, where are we going with this? I mean, this has the real potential to be scalable and accessible to everybody in their home, and offer ways for patients, I think, to receive what we are calling multidisciplinary care. Multidisciplinary care addresses mental health, diet, nutrition, education, just learning about the disease, physical health, in so many different kinds of ways. And I think that there's a lot of potential. We at Cedars-Sinai have treated over 3,500 patients with VR to address pain in the hospital successfully with NIH-sponsored clinical trials. And we have a large VR development lab. We're actually starting a clinical trial right now in IBD using virtual reality to treat anxiety for patients. And again, it's specific to inflammatory bowel disease. And I think that we're recognizing the huge potential for this technology. There's also been a real shift, I think, in the research to address some of these issues like mental health challenges that we know are experienced by many people with inflammatory bowel disease. And in fact, Connecting to Cure has generously given us a grant for a research project that will be beginning in the next few months to specifically look at mental health in patients with inflammatory bowel disease using a novel, accessible program. So thank you very much for that. And it really helps, I think, to move the field forward when we recognize that treating inflammatory bowel disease is not just about treating the inflammation, but it's about treating the whole person. And now we have emerging technologies that will help us do that on a scalable fashion. Next slide. I just want to share with you, this is another potential snapshot of what AI could do. Apologies for those that are uncomfortable about the picture on the left. We did a study, we published this last year, that we had patients take photos of their stool in the toilet, and we trained an AI model to predict and correlate that with their CRP, their blood marker for inflammation. And we did this with patients in the hospital who are getting daily CRPs drawn, and we found that we could actually train a model to help that. Now, is that going to be something that's going to emerge in the future? I don't know, but wouldn't it be really, a huge step forward in terms of quality of life to be able to take a picture of your stool in the toilet, have the AI figure out what does that mean for my disease activity? Does that mean I need to go in? Am I having a flare? Is the drug working? A whole bunch of questions we could answer potentially with this kind of technology. Whereas right now we have to rely on colonoscopy and stool tests in order to give us the answer.
Yeah, it would be great if you could do the CalPro. I thought that DDW last year they talked about maybe being able to test the inflammation from the stool
Yeah,
or something, and but also like just the like if you have C. diff. I know that. I mean, I'm just saying, like, so you don't have to like go bring it to the lab would be amazing to
yeah,
figure
yeah,
that out. Yeah.
yeah, yeah. Home calprotectin tests. I do see coming very soon. You still
Yeah.
got to handle the stool, but here maybe we can train AI models through a photo to do the
Yeah.
same.
Yeah.
We're just coming to the end. I have a couple more slides. This is just a quick word about ultrasound. Some of you may be familiar with the use of ultrasound. It's old technology, but it's new in IBD. And we're now able to see things on ultrasound with Crohn's and ulcerative colitis that allows us to monitor patients with non-invasive methods, in some cases avoiding the need for a colonoscopy, and in many cases allowing us to do repeated measures, whereas we couldn't typically or feasibly do repeated colonoscopies or even stool calprotectins. This gets to be annoying. So ultrasound, and I've shown here where I think ultrasound could be going. We already see, as in the picture on the right, there are now home ultrasound devices that you can connect to your iPhone. And here in this case, a pregnant woman is reassured that she can see the heart rate, the heart beating of her baby. And we can foresee that in the future, handheld home devices, perhaps where AI can interpret what is being seen on the ultrasound, or those images could be sent to your doctor so that you don't need to come in for an in-person procedure.
Oh my God, that'd be incredible.
Yeah, it's coming. It's coming.
Yeah.
So in summary, I've talked about a lot of different things. Translational research offers the opportunity to tailor the discoveries and bring them to the clinic. We can do better with our older drugs, even though we've got newer and better drugs coming out. We've learned how that our older drugs can actually be used in better, safer, and more convenient ways. I talked about surgery. Surgery, unfortunately, is still common in IBD, but we can do better with surgical outcomes with prehabilitation. In my opinion, the greatest advance in the last few years is this concept of early treatment. I think that's where we have the greatest potential to really bend the curve for complications that we still see with IBD. We also know that the research is helping populations of patients to impact on a large scale. I think the future is really in future is now, and in many cases with telehealth and home monitoring, as well as disruptive technologies like AI and VR that are here now, and we're just starting to learn how we can potentially apply them to inflammatory bowel disease. In my opinion, the next frontier for IBD drug development is predictive and companion biomarkers to predict which drug will work or which drug will be safe or unsafe. And then also treatment of fibrosis, scar tissue, and probably also fistulas, which I didn't really talk about, but we have, I think, drugs coming that will do better than we currently have. And then, really it's thinking about that technology, as I mentioned, leveraging what is already here. And AI is only getting better every single day, and using it for good, using it for leveraging it for the abilities that we can from a technological standpoint to ultimately bring a lot of the things that we do in the clinic, in the procedure room, to the comfort of your own home. So I'll stop here and I'm happy to address any further questions. Thank you very much.
Thank you, Dr. Melmed. That was really fantastic. I learned so many things. That's what I love about hearing these talks is there's always so much to learn. It was so interesting talking about the damage, the chart that you showed where the damage is still happening when, even though there's a flare, but in between the flares if it's not treated correctly. So I just always want to, stress because people sometimes think, oh, my symptoms are better, I'm fine, or I can go off my meds. And, it's like the meds are doing their job, and that's why you're, staying healthy. And it's not only about the symptoms, it's about the future. And even as you talked about, like starting early treatments, if people are concerned about that, and just to like have this information to like sort of ease their anxiety about the medication and just see how beneficial it can be. So I really appreciated that. But is there any, there are some questions in the chat, I think.
So I see that somebody asked about, oh, I'll go in backwards order. Is it safe for UC and Crohn's patients to take GLP-1 medications that have GI side effects? My answer is a resounding yes. Yes, not only do I think it's safe for people with IBD to take GLP-1s, but I think it may actually help some people. In fact, there's good data now coming out from dozens of institutions around the world that patients would take these medications for other reasons, for diabetes, for obesity, who happen to have IBD, their IBD also gets better. And so we actually have two clinical trials going on at Cedars right now, looking at GLPs for the treatment of IBD. They do have GI side effects. So the diarrhea that you might get, or the nausea, or the bloating that you might get from a GLP-1 doesn't mean that you're flaring your IBD, but you may be like a lot of people out there that do get GI symptoms. There's a question about ultrasound. Why are so few institutions employing it? Unfortunately, there's a real steep learning curve. I had to go out of the country to learn ultrasound. I think now we're having more and more courses in the United States to learn ultrasound, but it is a very steep learning curve. I think over the next 5 years, we're going to see many more centers coming online as more and more people get trained. And that'll be in the United States. In Europe and North America, it's more common.
Um,
There's a question in the chat about infliximab or Remicade, the percentage of people are getting injections. Is the timeline the same? What is the cost differential? I will say that many people who are doing well on infused Remicade, or by the way, a Remicade biosimilar today, which is very similar to the drug is still infliximab, choose to continue that, even though we have injectable versions available now. I recently visited Korea, where injectable Remicade first came out. That's where it was developed. And in Korea, about 60% of people are now using injectable versions of infliximab. So I think that it's really going to be is it offered? Is your insurance going to cover it? Is it something that you want to do? The injection itself is every 2 weeks. The infusion is every 8 weeks. So there is a bit of a trade-off there, and that's something that people need to consider. But it is available, and in fact, the efficacy of injectable infliximab seems to be as good as the infused version when they've done clinical trials randomizing people to continue the infused version versus switching over to the injectable version. Similarly, Entyvio also, it was actually approved in 2014, and then in 2024 we had an injectable version that was approved and came out and became available in the United States. And so many people are on infused Entyvio also every 8 weeks, now have an option to receive Entyvio as a subcutaneous injection.
Sarman, did you have a question?
Yes. First of all, thank you, Dr. Melmed.
It's Armin.
How are you? Just want to say thank you for everything you do and all the physicians, for people that suffer. It's great to know there's medication and people that can help guide us. But one thing I wanted to get your thoughts on, Dr. Melmed, was you mentioned in the slide like the increase in medication, right, by the pharmaceutical companies, which I mean clearly to me test shows there's an increase, right, in people having IBD. And the pharmaceuticals, obviously, as much as we love them, they're in the business of making money, right? They're not like goodwill institutions. So, in some ways, it's a good time to have UC because there is so much medication to treat. But is there, as far as like doctors and as far as the pharmaceuticals go, is there um, an effort to find like what is that underlying issue that there is an increase, right, in UC Crohn's and other IBD? So just curious to get your thoughts on that, and if potentially one day there can be a discovery in as far as that goes.
Yeah, thanks. So, just to be clear, you're asking, is there an underlying reason why people get IBD?
Yeah, like an effort to find that out,
Yeah,
right? Like research in that
yeah,
direction
yeah.
versus
No,
just producing more medication. Again,
yeah, I mean, there's a lot of efforts that have been ongoing for decades, and they range from environmental exposures to genetic defects to immune system being overreactive. Are there things that we're exposed to perhaps in early life, or things that we're not exposed to in early life? So all of these things sort of interplay. I think that it's very unlikely that there will be one answer to your question. There are what we call monogenic diseases, where there's one gene and that explains the entire disease. That's not the case in IBD. We already have over 500 genes that have been identified as susceptibility genes for Crohn's or ulcerative colitis or both. And each one relates to a different pathway. And so that's why, I give the analogy of a piano. You're going to get sounds out of a lot of different keys on the piano. Sometimes you have a pedal that will mute all the keys, but you really IBD, I think, is a very complex condition where we're not going to have one answer for all of IBD. We may have an answer for some of IBD, maybe perianal fistulizing Crohn's disease, maybe limited ulcerative colitis that stays only in the rectum and doesn't progress. I think we're learning that we have to segment IBD into different kinds of IBD, and I think in the future we will be tailoring our therapies to those different kinds of IBDs. Right now, we're very broad just because we don't have the sophisticated understanding to break it up into lots of these different subtypes. But they behave very, very differently. And so I think there isn't going to be one answer for all of them.
Yeah,
And
thank you. Do you want to take one more question that's in the chat from Betty? What is your opinion on all the microbiome research for IBD? And do you think there will be some more specific answers will come from this research besides what we already know about eating fiber and different food things? And I know there's other ways that of changing the microbiome as well as besides diet, but I guess what's the status of that? I'm sure that's a long question, but just in general.
Yeah, I mean, look, there's a lot of microbiome research going on, and we do a lot of microbiome research at Cedars. There's a huge interplay between the microbiome and someone's genes and someone's immune system, and the microbiome gets influenced by what you eat, antibiotics that you take, and other environmental exposures like air pollution and cigarette smoking and all sorts of things that we are exposed to. So it's complicated. I think we now have more computing power than ever, and that's helping us look at very big data sets like microbiome data sets. I don't know that there's going to be, again, to the prior question, there's going to be one solution for saying that the microbiome does or doesn't have the answer. Um, we don't yet have a microbiome-based therapy for Crohn's disease, despite 20 years of research and hundreds of millions of dollars of research. We do not yet have that. And it's not because we haven't tried and we haven't looked. We do know that there are certain diets that work better, and manipulating the microbiome in that way can be as effective as steroids in some situations. But we don't yet know how to predict which situations, and we don't yet know really how to apply it in a sophisticated enough way to make those treatment recommendations broadly and universally. Do I think we'll get there? I don't know. What I think maybe is more likely is that we're going to be combining microbiome-based approaches with our pharmacologic therapies. And so we'll say, well, this biologic drug works best when you go on this particular diet. And we'll use diet as a combination therapy, if you will, together with pharmacologic treatments.
Yeah, I think that's already starting to happen. Just anecdotally speaking to people in our community who are, they're on medication and then they're also on the diet and they need to be on the diet as well, and which makes them feel a lot better. So it sort of elevates the medication and its effects. Anya, did you have a question before we go? I don't want to keep everyone, and Dr. Melmed's going to a conference tomorrow, I guess, but do you have a question, Anya?
Yes, well, not really a diet, but nutrition based. Is there a research or a program that will tailor nutrition to a specific patient? The reason that I'm asking is because, I mean, they have a patient in the family and he is clearly not absorbing food properly, but the advice from nutritionist is like eat more. But that obviously doesn't work. And it's not clear. So what do you do? Like, like maybe there's a researcher program that can look at his blood test or his other biomarkers. I don't know. But like with all the abundance of food available around, for someone to be malnourished is, I don't know, frustrating. So is there a program like that?
It's hard for me to give specific guidance for an individual patient. But I will say that when we think about diet for IBD, there's really two different categories of diet. There's addressing malnutrition, which is maybe what you're talking about, and that's when people are just not getting enough calories, they're not getting enough nutrients, and that's because the disease is interfering with their proper absorption, or in some cases, burning through the calories with so much inflammation. That needs to be addressed in a very specific way to address those deficiencies, micronutrient deficiencies, protein deficiencies, and really maximizing with what you can eat, how to get back what you're deficient in. Then there's a whole other category of research which has to do with using diet to heal inflammatory bowel disease, and that's a little bit different. I think that's more along the lines of what Betty was asking, was manipulating the microbiome in a way that minimizes the inflammation, and so that's a different sort of way that we think about diet. I think in your case, it's working closely with the dietitian, working closely with the physician to identify what are the deficiencies and then coming up with solutions of how to address those deficiencies.
Thank you. Well, there's one other question. This might be a quick question about Rinvoq for patients with perianal fistulizing CD.
Yeah, yeah. Um, Rinvoq is a JAK inhibitor. It's a small molecule. It's a pill. It's a drug that was recently approved for both Crohn's disease and ulcerative colitis. Um, the data are not yet fully out. So what I'm saying is based on preliminary data that we've seen when they've taken patients in the large scale clinical trials with Crohn's disease, and they looked specifically after the study at those who had fistulas or perianal manifestations and what was the effect of Rinvoq in those patients. Um, we're seeing some very positive results where patients with all sorts of perianal manifestations have had improvement in fistulas closing, skin tags getting smaller, anal ulcers disappearing. So I think that we're very excited as a IBD community. Now there are larger trials specifically focusing on perianal fistulizing Crohn's disease that we are waiting to see results from. Right now, today, when we think about perianal Crohn's disease, we think about two drugs, infliximab or Remicade, and Rinvoq now.
Oh, okay. Yeah, that's great. That's really exciting to hear about that, and also the TLA1 drugs that you talked about for stricturing, because I know there was no really medication to address those, that particular type of disease. So thank you for sharing that. And also I wanted to say thank you everybody for joining. I know there were some other questions that people had left beforehand. So what we're going to do is kind of just create a summary of the talk. And I think some of those questions have been answered and addressed, and we'll try to address as many as we can and send it out to everybody. Also, thank you so much. We're very proud to support Cedars-Sinai, and as I mentioned before, because of all our support groups and our focus on the community and patients and caregivers, we really appreciate Cedars and you're always had a focus on the holistically on the whole patient, but just increasing that with the program that you're starting and that we're happy to contribute to. And also thank you so much for taking the time out to be here with us tonight. I think it was really valuable, and I know patients really appreciate hearing directly from doctors, especially someone like you, Dr. Melmed, because you're such a fantastic member of the IBD medical community and just the general community as well. So thank you so much for being here.
Thank you, Stacy. It's been a real privilege, and I really enjoyed speaking with you and everybody here. So thank you for your engagement.
And if any, yeah, and then, like I said, if anyone has any questions or wants to know more about us or anything, please reach out to us.